Hey guys, my name is Shrek Harigaonkar, and today I will be talking about plasma cell neoplasms and the related entities. All right, so the important points. Whenever you start talking about any question during the pathology final, you want to talk about, you want to set a specific framework and then basically build up on that. So initially we talk about what are plasmacytic tumors, like the definition, the example of the plasmacytic tumor. So multiple myeloma, which is arguably the most important one. You have primary or immunocyte associated amyloidosis, which is the complication of multiple myeloma. You also have MGUS, Waldenstrom's macroglobulinemia, and solitary plasmacytoma. All right. So regarding plasmacytic tumors, so these are basically defined as monoclonal B-cell proliferations that lead to that transformed into neoplastic plasma cells that always secrete single immunoglobulin and immunoglobulin fragments. So these are usually characterized by what is known as M protein and Bence-Jones protein. So the M in M protein basically stands for myeloma protein, and it's involved in the diagnosis of most plasmacytic tumors. So over here in this picture, you can see what a normal serum electrophoresis looks like in blue, and you can see the orange one, which is in a patient with multiple myeloma, you have what is known as the M spike. So the M spike basically comprises of gamma globulins. So these are mainly immunoglobulins, and since they're too large, they don't pass in the urine. On the other hand, you have Bence-Jones protein, which are basically excessive light chains, and these are usually secreted in the urine. So you can find these in the urine. In this picture over here, I just wanted to show you what a plasma cell basically looks like, as well as you can see how it develops from the B lymphocyte. So regarding multiple myeloma, so multiple myeloma is defined as a malignant plasma cell dyscrasia characterized by uncontrolled proliferation and the diffuse infiltration of monoclonal plasma cells in the bone marrow. So you want to mention monoclonal over here. So regarding the pathogenesis, it may vary. Uh, For instance, the most common one is chromosomal translocations associated with the immunoglobulin heavy chain locus on chromosome 14. And this usually involves translocation to an oncogene, like cyclin D1, for instance. And as a result of this, you'll have increased cell proliferation. You may also have deletions in TP53. So, deletions involving TP53 is often associated with a poor prognosis in these patients. And TP53, as you know, is a tumor suppressor gene. You also have rearrangements of MYC gene as well as mutation of NF kappa B. Regarding the cytokine involvement, so these two cytokines are the most important ones in multiple myeloma, and that's because in the case of interleukin 6, it's usually important for the growth of plasma cells. So it's a crucial growth factor for them, and their survival basically depends on interleukin 6. You also have osteoclast activating factor. So osteoclast activating factor basically activates the expression of rank on osteoclasts and rank L on bone marrow stromal cells, which in turn activates osteoclasts. And as a result of activation of the osteoclasts, you get the different features like the bone lesions and hypercalcemia associated with multiple myeloma. So in this picture over here, I wanted to show you guys the characteristic punched out lesions in multiple myeloma. So you can see these lesions over here. They look like someone's basically punched them out. And these lesions can occur anywhere, but they're most predominantly occurring on the skull as well as on the vertebra. And these often associated with like bone pain and hypercalcemia. Um, the hypercalcemia can also give rise to neurological manifestations as well, like fatigue, tiredness, muscle pain, for instance. You may also have elevated serum protein, so that's usually greater than 3 grams per deciliter. So it's important to use electrophoresis. This allows us to see the elevated serum protein and also the sharp M spike as mentioned in the electrophoresis. Serum albumin is usually normal in these patients, and the examiner might ask which is the most common immunoglobulin that's usually elevated in multiple myeloma. So the answer to that would be IgG. and then after that would be IgA. You also have what is known as myeloma nephrosis. So this is basically a renal involvement in the case of multiple myeloma. And you have Benz-Jones proteinuria. So basically where you have the cast of the Benz-Jones protein. So these casts usually obstruct the distal convoluted tubules as well as the Purkin ducts. And these proteins in general are usually toxic to the epithelial cells of the tubules. As a result of this, you may have necrosis and atrophy of the cells, giving rise to what is known as your myeloma nephrosis. Regarding microscopy, so one important finding on blood smear is the roller formation on blood smear. So these are usually characterized because, so it's basically where you have these red blood cells. So this is the RBC, and you have basically the stacking up of red blood cells on the peripheral blood smear. And this is mainly due to the increase in the serum protein, which basically interferes with the charge of a RBC. And as a result, you get the sticking up or stacking up of the RBCs. And this also leads to a markedly increase in the erythrocyte sedimentation rate. And there's also increased bleeding time because of this. Um, you also have increased number of plasma cells in the bone marrow. So this picture over here is basically a bone marrow slide. And in this, you can see your different kinds of like the plasma cells basically. And this basically like different kinds of abnormality that can be seen within these plasma cells. The most characteristic of that is the fried egg appearance. You may also have flame cells, which are they have like a fiery red cytoplasm, or you may have moth cells as well. So these are basically cells with grape-like cytoplasmic droplets, as you can see over here. So this over here would be a moth cell, and you may also have Russell bodies or Dusher bodies, which basically refers to the inclusions within these cells. You may also have renal findings. So renal findings, as I mentioned, you may have proteinaceous tubular casts. So the Bench-Jones protein renal disease, you have the casts which are basically nephrotoxic and damage the renal tubules. Um, you may also have nephrocalcinosis, as mentioned, because of hypercalcemia. You may have like stone formation, for instance. That's a possibility. Um, Apart from that, regarding the clinical features, there's bone pain as mentioned and neurological manifestations because of the hypercalcemia. Regarding the complications, so there's usually an increased risk of infection. So that's because monoclonal antibodies lack antigenic diversity. Infection is the most common cause of death in these patients, and sepsis is commonly due to Haemophilus influenza or Streptococcus pneumoniae. Because the pathology bone lesions, you may have fractures as well. You may have primary AL amyloidosis, and is basically where the tumor cells overproduce light chains, and these deposit in tissues. Myeloma kidney, as mentioned, may lead to renal failure. You may have plasma cell leukemia. This is where the tumor cells flood the peripheral blood. You may also have evidence of end organ damage. So there's a specific mnemonic called CRAB, which stands for calcium elevation or hypercalcemia, renal insufficiency, anemia, as well as bone lesions. So the anemia basically occurs because of crowding of the bone marrow. And anemia is the most common finding, but you may also have thrombocytopenia as well as neutropenia. Then you have MGUS, so which basically stands for monoclonal gammopathy of uncertain significance. So defined by, it's characterized by complete or incomplete monoclonal immunoglobulins detectable in patients without accompanying clinical symptoms. So the main difference between MGUS and multiple myeloma is that uh, there is no pathologic clinical manifestation in the case of MGUS. So there's no lytic lesions, there's no hypercalcemia, no amyloidosis, no Benjamin's proteinuria. The only thing about this is the M spike in the electrophoresis, and other features of multiple myeloma are absent. And therefore, it's important to discriminate this from multiple myeloma by checking all the other signs of multiple myeloma. Patients are usually asymptomatic, and in rare cases, 1% of the patients might develop into multiple myeloma. Right. And then you have Waldenstrom's macroglobulinemia. So it's basically defined as a B-cell lymphoma. So this is different from the others in that it's actually a lymphoma. And you have monoclonal IgM production. And therefore the disease is called macroglobulinemia because the IgM molecules are pretty big. Mhm. It differs from CSL in that the fraction of tumor cells undergo terminal differentiation into plasma cells. And the high IgM levels basically lead to what is known as a hyperviscosity syndrome. Um, we will talk about hyperviscosity syndrome in the next slide. Regarding that, in the diagnosis, you have increased serum protein with M spike, but this one is composed mainly of IgM. Benz-Jones protein also might be present, but however, you don't have any renal disease or amyloidosis in most cases. So regarding the clinical features, as mentioned, since it's a lymphoma, so you're going to have lymphadenopathy as well as a hyperviscosity syndrome. So these are usually associated with basically like thickening of the blood, and you may have hypertension, visual impairment, neurological problems, bleeding, cryoglobulinemia, etc. Regarding the treatment, the examiners won't ask you the treatment mainly, but I feel it's good to have an idea. So one thing you need to know, you would like to know, I guess, would be plasmapheresis, as well as chemotherapy and biological therapy. So in plasmapheresis, you basically remove all the excess protein that's present within the blood. So this does seem to decrease the load on the patient. And finally, you have solitary plasmacytomas. So these are basically solitary aggregates of plasma cells, and these may be located within the bones or outside the bones. So within the bones, the precursor lesions, they may develop into multiple myeloma. There might be low or no serum M protein, and half of the patients usually progress to multiple myeloma within 4 to 5 years. Outside the bones, also known as extramedullary plasmacytoma, is usually found within the upper respiratory tract, and these are not precursor lesions for multiple myeloma, and they can simply be cured by local resection as well. So these are the references used, and that's all. Thank you.